Hello again, ladies and gentlemen, and welcome to my updated talk on flutters and fibrillations. This is part of a series of talks that I'm doing on arrhythmias, and this is an updated talk because not only did I want to include some more information, some more strips that you can look at, and present them to you in beautiful high definition, as I now have the ability to do, but also because it's come to my attention that there have been some audio issues with some of my videos, and so I'm kind of not only addressing that with YouTube, trying to get that fixed, but also taking the opportunity to just replace some of those videos with updated talks. Again, not a lot of changes in the management of these disorders, but I figured I'd include some more strips and stuff that might help you discern some of these rhythms. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button in the upper right-hand corner up here. And if you do, it will link you up to my page. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. And if you subscribe, you'll have access to some of my premium videos in which I go over case studies, how to formulate differential diagnosis, treatment plan, things that will come in useful for you as you gear up to study for Step 3, which, as you know, has a non-multiple choice section. Very important to be able to organize your thoughts, make that differential diagnosis, and then go forward with a treatment plan, a diagnostic workup. They're really going to be looking for you to be able to do that. And also, it's very important to know how to do that when you're on the wards. You'll be able to impress your attendings by being able to put that together on the fly. So thank you very much in advance for your consideration, and we will now get started with our flutters and fibrillations. So here we have flutters and fibrillations. It's part of our talk on arrhythmias. Bradyarrhythmias, tachyarrhythmias, premature contractions, pre-excitations I go over in other talks. So as you can imagine, if you hear the word flutters and fibrillations, the very first thing that should come to mind is atrial fibrillation. And by far and away, the most common arrhythmia that you will ever encounter is atrial fibrillation. So we're going to spend the bulk of our time talking about atrial fibrillation, not only because the USMLE is going to expect you to know what that looks like on a strip, but they're also going to want you to know how to treat atrial fibrillation, how we go about managing atrial fibrillation, what are some of the complications, what are some of the causes. You need to know that. Atrial flutter, ventricular fibrillation, more so important, well, particularly for atrial flutter, but more so important that you're able to identify it. The treatment and management of atrial flutter is much the same as for atrial fibrillation. So if you know one, you know both for the most part. Ventricular fibrillation, it's an emergent, life-threatening issue, typically leads to a code blue. I talk about code blue in another one of my talks. You can go back there as we talk about the treatment, but we're going to just briefly identify ventricular fibrillation in this talk because we're talking about flutters and fibrillation, so we can't ignore ventricular fibrillation. So let's start out with atrial fibrillation. Atrial fibrillation is uncoordinated electrical activity of the atria, ultimately resulting in irregular activation of the AV node, which, remember, initiates ventricular contraction, and then, of course, is going to lead to an irregular pulse. If you have irregular activation of the AV node, which results in contraction of the ventricles, and that's causing your pulse, then you're going to have an irregular pulse, in particular, an irregularly irregular pulse. So there are some differences between atrial fibrillation and atrial flutter, which we'll go into in a little bit, but this is just uncoordinated electrical activity of the atria. There are a variety of causes. I highlighted the ones in red that I think are the most important to know because they're more common. But as far as acute causes, pulmonary disease and ischemia. So you have a patient with a recent heart attack, very common for them to develop an atrial fibrillation because there can be damage to the atria, which then can lead to discoordinated electrical activity. Pulmonary disease can expand the atria, and that can disrupt the normal electrical impulses through the atria. Rheumatic heart disease, we really don't see much in the U.S. because of immunizations and because of treatment for streptococcal infections. Anemia, atrial very really not very common. Thyrotoxicosis, I suppose that's useful to know, not because thyrotoxicosis commonly leads to atrial fibrillation, but because it's something that we need to rule out in our workup. Alcohol abuse, and then sepsis. And so you can remember the mnemonic PIRATES. Chronic causes include hypertension, valvular diseases, and congestive heart failure. So really for atrial fibrillation, think of ischemic causes and then anything that can dilate those atria. Because if you're dilating the atria, you're really expanding the and disrupting that normal electrical structure that you have, that normal mode of transducing electrical impulses from the from the SA node to the AV node. And so if you disrupt that, then you're going to have some irregularities, and that can disrupt the activation of the AV node and ultimately lead to an irregular pulse via atrial fibrillation. So the ones I want you to remember are pulmonary disease, ischemia, valvular disease, and congestive heart failure. Okay, so there are many causes. As mentioned, mostly this is an acquired syndrome. You typically don't get atrial fibrillation out of the blue in healthy people. It is diagnosed on EKG, so often atrial fibrillation is asymptomatic, but when it is symptomatic, it's typically going to be due to that irregular pulse, and more particularly, what's going to happen with atrial fibrillation is that because you have discoordinated atrial contraction, you're not going to fill the ventricles as efficiently, and so your cardiac output is going to go down a little bit, and that can lead to some issues with syncope and dizziness and stuff like that. However, most of the time atrial fibrillation is asymptomatic, and so you'll diagnose it coincidentally on EKG. So what do we see on EKG? Well, we see erratic, low amplitude activity where we would expect to see our P waves. And that makes sense because the disorder here is in the atria. And so if you have uncoordinated electrical activity in the atria, you're not going to have those normal coordinated P waves. And so what you see is just abnormal pre-QRS activity. We can't even call it a P wave. And so because there's no single impulse that completely depolarizes both atria, there's not going to be any P waves. So we say erratic, low amplitude pre-QRS activity. I'll show you a picture of what that looks like. It should become pretty clear. Physical exam, the only thing that you'll typically see with all patients with atrial fibrillation is an irregular pulse. You don't have coordinated atrial depolarization that leads to ventricular depolarization, and so because it's uncoordinated, you're going to have irregular pulse. And so you're really just getting ventricular contractions at random moments. So if you diagnose atrial fibrillation by EKG, then you're going to want to get a variety of tests. And chief among these are a chest x-ray. And the reason you want to get a chest x-ray, remember, is one of the more common causes of atrial fibrillation are pulmonary related. So you want to identify any possible pulmonary disease, looking for things like pneumonia, COPD, congestive heart failure, which remember you'll see engorgement of the vasculature. You'll want to get echocardiography, and that's, again, to exclude vascular diseases. You can assess the heart size and shape, looking for changes maybe associated with a cardiomyopathy or with congestive heart failure. Look at the chamber sizes, the valvular structure. Remember, valvular disease is a possible cause. And then also you want to look for wall motion abnormalities, because one of the big complications that can come out of atrial fibrillation is a mural thrombus, and that typically happens because of hypomobility of the atria. Atria aren't moving as much, you can develop a thrombus, If that thrombus develops in the left atrium, that can get thrown out into the systemic circulation and lead to one of the more feared complications of atrial fibrillation, which is a stroke. Thyroid function tests can be useful to exclude hyperthyroidism, which is one of the more correctable causes of atrial fibrillation. Not terribly common, though. The major concern, as I mentioned, is a mural embolism, and that's due to stasis. So because you don't have coordinated atrial contraction, those atria are kind of just, well, fibrillating. They're not really moving too much. And so because you have that stasis, you can develop a clot, and that clot can then get thrown out into the general circulation, the systemic circulation, and that can migrate up into the cerebral circulation, and that's going to cause a stroke, either a TIA or just a regular old stroke. So that's the feared complication from atrial fibrillation. Atrial fibrillation can also result in a rapid ventricular response, which is just a fancy way of saying a tachycardia, a severe tachycardia. And because this is a tachycardia that's associated with impaired ventricular filling, this can cause hemodynamic instability because you're not getting blood out into the systemic circulation. And so you can get a drastically reduced blood pressure and syncope, and ultimately you can have hemodynamic collapse. So this is an example of sort of what happens with atrial fibrillation. So notice that we have this normal electrical pathway here. You get conduction from the SA node down the atria, ultimately leading to the AV node, which then conducts through the ventricles and leads to ventricular contraction, depolarization. So you can see here you've got a heart rate, a regular heart rate of approximately 90 to 100. With atrial fibrillation, there's these abnormal electrical pathways. You no longer have coordinated activity between the SA and AV node. You have these multiple focuses, which then is going to result in this abnormal pre-QRS activity because you don't have coordination between the SA and the AV node. And this is very similar in pathophysiology to what we're going to talk about next, which is atrial flutter, with one significant difference, which we'll get into. So you have all these little ectopic pacemakers conducting down to the AV node and really giving it irregular input. And so because there's irregular input, the AV node is not really going to know what to do. And so it's going to send its impulses down the ventricles at irregular points, and that's why you get this irregular rhythm. Okay, so it's just a lack of coordination between the SA and the AV node due to pathology of the atria. So this is what atrial fibrillation looks like. So just to compare, here you have a normal EKG. And then with atrial fibrillation, you can see you've lost your P wave. Now you've also lost your T wave, but the T wave is actually there. It's just obscured. Remember, the T wave is the repolarization of the ventricles. That's going on here. It's just because there's all this erratic activity in the atria, it obscures the T wave. So you're not going to see your T wave, but it is actually there. So here you can see just irregular activity between your QRS complexes. So there is an absence of a normal P wave because you don't have normal coordinated atrial depolarizations. Now, you probably won't be asked this on the USMLE, but you will be expected to discern the heart rate of a patient with atrial fibrillation. That's not always that easy to do because it's irregular. But really, all you need to do is go through 6 seconds. Remember, that's going to be each second is 5 big boxes, so 30 big boxes. Count the number of QRS complexes, and then multiply that by 10. Because we're going 6 seconds here, so you want to multiply by 10. So here we have 4, 5, 6, 7, 8, 9, 10, 11, 12, multiply that by 10. This is an irregular rate of approximately 120 beats per minute. So again, here you have atrial fibrillation. This is a little bit nicer here, a little bit less severe because you can actually see your T waves. But notice the irregular pattern and an absence of P waves. And you have this really fine fibrillation here. And this stands in contrast to what we're going to see next, which is atrial flutter. So again here you can see kind of this is a little bit more severe, I guess you could say. You don't really see your T waves very well. Again, you see your irregular pattern. And this is a heart rate of about 120 again. Okay, and here's one more. Okay, so the treatment for atrial fibrillation, we do need to treat it, very important. The cornerstone of management is going to be rate control and anticoagulation. Rate control is going to help promote proper rhythm, and that's important because we need to preserve our cardiac output. If we can get the atria to put enough blood into the ventricles, that's going to reduce your risk of syncope and all those nasty things that can come out of atrial fibrillation because you're not adequately filling your ventricles. So the idea is we want to slow the heart down. We're not actually fixing the arrhythmia. What we're doing is we're slowing the heart down. And by slowing the heart down, we allow the atria we allow the ventricles more time to be filled. And because we're allowing the ventricles more time to be filled, we're improving the cardiac output. So we really want to slow the heart down, rate control. And that promotes, I guess you could put proper rhythm in quotation marks because we're not exactly doing that. So that's rate control. Anticoagulants are done for another reason. That's to prevent the major complication, which is stroke. So we want to prevent the formation of a thrombus, and we do that via anticoagulants. So rate control and anticoagulation. So what do we do for rate control? The ideal medication for rate control is calcium channel blockers. Now, traditionally, we have viewed calcium channel blockers as preferable to beta blockers, and beta blockers as preferable to digoxin. They are all possible treatments, but traditionally we use calcium channel blockers. There's some literature that says that calcium channel blockers and beta blockers are equivalent, but the traditional wisdom is that calcium channel blockers are the best. So I will still convey to you that calcium channel blockers are the agents of choice. Now we do want to use the non-dihydropyridine calcium channel blockers. Remember that the dihydropyridine calcium channel blockers are anything that end in dipine, so amlodipine, nifedipine. We do not want to use those. We want to use the non-dihydropyridine calcium channel blockers. So that's things like diltiazem and verapamil. So those are the agents of choice, and they slow down AV conduction. The goal for rate control is a resting rate of less than 80 beats per minute. As mentioned, beta blockers and digoxin are also effective, but you need to know that calcium channel blockers are the best treatment of choice for atrial fibrillation. Anticoagulants are used to reduce the formation of mural thrombus, which also then is going to consequentially reduce the risk of stroke. In this case, warfarin is preferred, but if the patient has contraindication for warfarin, you may substitute an antiplatelet drug like clopidogrel. And whether you use warfarin or something like aspirin is going to depend on their CHADS-2 score. I would say for the USMLE, just go for warfarin because they're probably not going to get that detailed, but in practice, some patients can get by without warfarin, and we'll go into when that is. But for the USMLE, patients with atrial fibrillation need to be anticoagulated with warfarin. And like any patient who's on warfarin, you need to monitor their INR. The goal INR for patients with atrial fibrillation is between 2 and 3. So you want to keep them within that range. Cardioversion can be used, but medical treatment is preferred. If you do undergo cardioversion, you want to get a transesophageal echocardiogram to ensure that there's no left atrial thrombus, because you can imagine what would happen. If you got a patient who's got a left atrial thrombus and you cardiovert them, and now all of a sudden their atria and their ventricles are contracting normally, that thrombus is going to be, in short order, pushed into the left ventricle and then out into the systemic circulation, and now you can cause that patient to have a stroke. So you want to make sure before you do cardioversion that there's no left atrial thrombus. Now, in emergency settings, let's say you have a patient with atrial fibrillation with hemodynamic instability, and of course, by hemodynamic instability, we're talking about hypotension, acute congestive heart failure, weak pulses. In this case, you want to do an immediate progressive cardioversion starting at 100 joules until sinus rhythm is achieved. Now, is there a risk of stroke after this? There absolutely is. If they've got that thrombus and you've cardioverted them, and now they're in a normal sinus rhythm, they've got a serious risk of throwing a clot. But obviously, when you've got hemodynamic instability, you need to address that first. So that is a complication that can come out of it. But when you're dealing with hemodynamic instability, we really don't have time to worry about complications. We need to get that patient stable. But as mentioned, if you have a patient with just atrial fibrillation and they're stable, you're not going to cardiovert them unless you know that they don't have a left atrial thrombus. If you have atrial fibrillation with rapid ventricular response, which is going to lead to symptoms like palpitations, chest pain, hypertension, and syncope, then you're going to use a calcium channel blocker. And then, of course, patients who have symptoms of a stroke, you need to do your stroke protocol, and I talk about that in the neurology section, but this is definitely a complication that can come out of atrial fibrillation. And of course, your stroke symptoms you should be aware of. So the CHADS-2 score is something that we evaluate in patients with atrial fibrillation to determine what their risk is of having a stroke within the subsequent year. So the CHADS-2 is just an acronym, and each of the letters, C, H, A, and D, are each 1 point, and the S is worth 2 points. That's why it's CHADS-2. So the C stands for congestive heart failure. If they've got that, that's 1 point. The H stands for hypertension. If they've got hypertension, that's 1 point. A stands for age. If they're more than 75 years of age, that's 1 point. D stands for diabetes. If they have it, that's 1 point. And S stands for stroke history. If they've had a stroke in the past, that's actually worth 2 points. So you add all those points up and you get this annual stroke risk. Do you need to know how to do your CHADS-2 score for the USMLE? Probably not. If you're taking ABIM for your internal medicine licensure, then yeah, probably you need to know how to do the CHADS-2 score by heart. Do you need to memorize the annual stroke risk? Absolutely not. But it's good to know for clinical practice that the CHADS-2 score is something that you'll make use of. There's calculators that you can use that are online, or you can put on your smartphone, and then you can determine what their CHADS-2 score is. CHADS-2 comes into use as far as management of atrial fibrillation, because if you have a patient with a CHADS-2 score of 1 or 0, then you may not need to use warfarin. You can actually get by using 81 to 325 milligrams of aspirin daily. However, with a score of 2 or greater, which is going to be most patients, then you need to use warfarin. So I think that's all. Yeah, I think that's all I've got for you on atrial fibrillation. Remember that we're doing rate control. Rate control is very important because it improves diastolic filling. That's going to improve coronary perfusion, and that can help with any kind of chest pain that's associated with atrial fibrillation. It reduces the myocardial oxygen demand by slowing the heart rate, and that can also prevent other things like cardiomyopathy, which can develop from the prolonged tachycardia. So very, very important here. And so that's going to conclude our atrial fibrillation. Now we can move on to atrial flutter. So atrial flutter is an atrial tachycardia, which is due to an atrial reentrant circuit. So basically here we have a reentrant rhythm, which causes a self-perpetuating loop. And so you've got this circular movement of electrical activity around the atrium. And this is going to be less irregular as far as that pre-QRS activity because you've got this loop going on, and this loop is going to be very regular. And so rather than that low amplitude sort of fibrillating rhythm, you've got this more regular, higher amplitude pre-QRS activity. Now, like atrial fibrillation, this can result in ventricular tachycardia because you've got this atrial activity going on, which can ultimately cause the AV node to send out an impulse down the ventricles. So it really is the atrial equivalent to ventricular tachycardia, which I talk about in the tachyarrhythmia section. And the EKG is going to show your hallmark sawtooth waves. Now, when you say atrial flutter, you need to say sawtooth waves because those two things are synonymous. And if you can identify your sawtooth waves, you'll diagnose atrial flutter. And I would bet that on the USMLE, if you get a question on atrial flutter, they'll probably just throw an EKG at you and ask you what kind of rhythm this is. So it's a very easy point on the USMLE. The sawtooth waves can be kind of characterized as multiple P waves occurring before the QRS complex. That's not really what they are, but it's kind of what they look like. Usually atrial flutter is asymptomatic, but because it's a form of tachycardia, it can have similar symptoms to atrial fibrillation because you're not adequately filling the ventricles. You can get palpitations just from the tachycardia, shortness of breath, lightheadedness, and syncope because of reduced cardiac output. And like atrial fibrillation, syncope will be much more likely to present if there is a rapid ventricular response, if that AV node is firing rapidly. As far as what atrial flutter is associated with, mostly going to be hypertension, coronary artery disease, and cardiomyopathy. So it is a type of supraventricular tachycardia here. So this is atrial flutter. You can see much different from the atrial fibrillation in that your pre-QRS activity is very regular because what you have is a reentrant rhythm. So you're just kind of, you've got this self-perpetuating loop, but it's identical every time. So you get the same looking oscillation here every time it re-enters. So that's what causes this sawtooth appearance. Now this looks fairly regular, and I would say that with atrial flutter, it is going to be a little bit more regular than with atrial fibrillation because you do have some coordination, but atrial flutter can also lead to an irregular pulse as well. So you have here a ventricular rate here of approximately 90. So you don't actually have tachycardia here, but atrial flutter certainly can lead to tachycardia. And the higher that heart rate goes up, the more likely you are to have syncope and reduced cardiac output. Okay, so again here, you see a little bit faster rhythm here, probably closer to 100, 110. Again, you have this sawtooth appearance. Now, if you have a really severe tachycardia associated with atrial flutter, it can actually mask that sawtooth appearance. So you can actually do vagal maneuvers to reduce the heart rate, and then that can uncover the sawtooth. So this is a really obvious sawtooth, and you can see that the sawtooth becomes a lot more apparent the slower the heart rate is. So here you can see the sawtooth rhythm right here. All right. So now this gets us to something we're going to talk about. Actually, we're going to talk about treatment of atrial flutter. Okay, so the treatment of atrial flutter, it's much the same as atrial fibrillation. So because a lot of the complications that can come out of atrial flutter are similar to atrial fibrillation, we're going to go about treating this in a very similar way. So rate control and anticoagulation. For rate control, we're doing the same thing, calcium channel blockers, and for anticoagulation, we're doing the same thing, warfarin. And the reason we do that not only is because we have a similar profile with atrial flutter as we get with atrial fibrillation as far as complications, but often atrial flutter will degenerate into atrial fibrillation. The cardioversion criteria are the exact same as atrial fibrillation. The one difference, however, is that atrial flutter can be cured with radiofrequency ablation. So we do have another way of treating atrial flutter that we don't for atrial fibrillation. So a very quick word on something called multifocal atrial tachycardia. Pretty low yield for the USMLE, but I had some people that were asking me about it. So I'm just going to put in a quick word here. So with multifocal atrial tachycardia, in this case, we have multiple atrial pacemakers or reentrant pathways that are not resulting in that self-perpetuating loop, but rather you have multiple sites, not the SA node, but multiple sites in the atria that are activating the AV node. And so you basically have, it's like having a lot of different SA nodes interspersed throughout the atria. And so in order to diagnose multifocal atrial tachycardia, you have to have that kind of pathophysiology, and then you need to have a heart rate of more than 100. So what I described with those different atrial pacemakers throughout the atria, that alone is called a wandering atrial pacemaker. And so if you just have that and your heart rate is normal, that's all you've got. So wandering atrial pacemaker. When that heart rate exceeds 100 beats per minute, then you have multifocal atrial tachycardia. So notice in the name, it's tachycardia. You have to have tachycardia in order to have multifocal atrial tachycardia. So what is this? On EKG, what you're going to notice, because you have multiple atrial pacemakers, different sites that are ultimately activating that AV node, you're going to have an irregular rhythm, but what you're going to see, and this is key, 3 or more P waves with different morphologies. Why do they have different morphologies? Well, they're activating contraction of the atria, electrical activity of the atria from different places. And remember that the EKG is just measuring electrical conduction in space. So if you've got origination of that atrial depolarization in different places, the P wave is going to look totally different from one to the next. The reason that our P waves always look the same in a normal sinus rhythm is because the P wave is originating from the SA node and moving in a coordinated manner down to the AV node. Well, if you have different areas of the atria that are initiating that activity, then you're going to have different looking P waves. They certainly are P waves because they are depolarizing the atria, but they're going to look different. And so because of this, you're also going to have varying PR intervals, and this is ultimately going to lead to an irregular rhythm. So let's take a look at this here. You can see that you've got a tachycardia here, but you also have a lot of different looking P waves. So you can see kind of a wider one here, a sharp peak here. You can see one here that's kind of being drawn into the QRS complex. You've got one here that's closer to the preceding T wave. So different looking P waves. If you have 3 or more, if you can identify 3 or more, then you have a wandering atrial pacemaker. But if you have a heart rate of more than 100 beats per minute, then you have multifocal atrial tachycardia. So the treatment for multifocal atrial tachycardia, again, is the same as for AFib and for atrial flutter, and that's calcium channel blockers or beta blockers. Why do you get multifocal atrial tachycardia? You may be asked this on a 99th percentile question on the USMLE. Multifocal atrial tachycardia, the most common cause is severe COPD. Okay, severe COPD. Sometimes it's associated with digoxin toxicity, but the most common cause of multifocal atrial tachycardia is severe COPD. I don't know why. I don't know the pathophysiology. That's all you need to know, though. As far as causes, multifocal atrial tachycardia is most commonly caused by severe COPD. So I guess that wasn't really a quick word, but now you know multifocal atrial tachycardia. Pretty low yield for the USMLE, but good to know. Okay, ventricular fibrillation, we're not going to spend that much time talking about because I talk about it in the code blue section. So this is a medical emergency. Obviously, with ventricular fibrillation, you have no coordination of the ventricles, and so your cardiac output is basically going to zero. And so that's going to cause hemodynamic collapse. And so these patients will always be hemodynamically unstable. They're going to be pulseless because you don't have ventricular contraction. Naturally, the EKG is going to show an erratic rhythm. You're not going to see QRS complexes. There's really not going to be any discernible features. The treatment is, as we go over in the code blue section, you want to have IV access, begin administering CPR, and prepare your defibrillator. You want to give one shock at the power appropriate for device, usually between 120 and 200 joules. Check the rhythm and then continue 5 rounds of CPR. You may be giving epinephrine depending on whether there's appropriate electrical activity. Again, I go into this in the code blue section, so you can get more information on that. You probably, if you're practicing in the U.S., going to medical school in the U.S., you've probably done your ACLS course, so you probably have some familiarity with this. All right. So here is ventricular fibrillation. You can see no coordination here. You kind of have this sort of sinusoidal wave appearance. It's definitely not asystole, but really no coordination, no discernible features. Now, ventricular fibrillation is not the same as ventricular tachycardia. So ventricular tachycardia, you basically just see abnormal QRS complexes. Ventricular tachycardia, I talk about in the tachyarrhythmia section. Ventricular tachycardia can have a pulse, but it doesn't always. But this is much more regular in appearance. It doesn't look normal by any means, but it's more regular in appearance, whereas ventricular fibrillation is lower amplitude and it's very uncoordinated. And so this is what ventricular fibrillation looks like on EKG. And that's all I got for you, ladies and gentlemen. If you want to go and learn about other arrhythmias, you can look at my other talks. Hopefully they have sound. Otherwise, I will continue to repair these videos, and I will see you next time.